Every year, your doctor draws blood, runs a metabolic panel, and hands you a piece of paper that says, creatinine normal. You breathe a sigh of relief. Your kidneys are fine. Except, here's what almost nobody tells you. A 2021 study published in the American Journal of Kidney Diseases found that nearly half of adults over 60 with genuinely reduced kidney function had creatinine levels that fell inside the normal range on a standard lab report. Not borderline, not slightly elevated, normal. Their kidneys were losing function year after year, and the single number doctors rely on most to catch it was quietly lying to them. This isn't a rare lab error. It's a structural blind spot built into the most common kidney test in America. And after 60, it's the reason kidney disease is called a silent disease. By the time symptoms show up, you've often already lost more than half your kidney function. Today we're going to talk about the test hiding behind the test, why creatinine fails exactly the people who need it most, and the 4 specific steps that catch kidney decline years before a normal lab report would ever raise a flag. Let's start with why this gap exists, because once you understand the mechanism, you'll never look at a basic metabolic panel the same way again. Creatinine is a waste product made by your muscles. Your kidneys filter it out of your blood, and the rate at which they do that, called the glomerular filtration rate, or GFR, is the real measure of kidney health. The problem is that doctors almost never measure GFR directly. It requires an invasive test, so instead, labs estimate it using a formula, and that formula leans heavily on your creatinine level, combined with your age and sex. Here's the catch. Creatinine production depends on how much muscle mass you have. A 35-year-old competitive weightlifter and a frail 72-year-old woman can have nearly identical creatinine readings, 0.9 milligrams per deciliter, both comfortably normal, while their actual kidney filtration rates differ by 30 or 40%. The weightlifter's high creatinine comes from muscle turnover, not kidney strain. The 72-year-old's lower muscle mass means her kidneys can be failing, and her creatinine still won't budge because there's less raw material being produced in the first place. A landmark 2012 analysis in the New England Journal of Medicine, led by Dr. Leslie Inker, found that adding a second marker, cystatin C, a protein produced by essentially every nucleated cell in the body at a stable rate, independent of muscle mass, improved the accuracy of kidney function estimates so significantly that it changed the diagnosed CKD stage for roughly 1 in 6 patients tested. Not a rounding error, a full stage reclassification. For people over 60 who lose an average of 3 to 8% of their skeletal muscle mass per decade after age 50, according to data compiled by the National Institute on Aging. This isn't a minor statistical quirk. It's a systematic reason why creatinine-only testing underestimates kidney decline, specifically in the aging population, the population that needs the warning most. Consider 2 real-world lab scenarios kidney specialists see constantly. A 68-year-old woman, 5'4", modest muscle mass after years of joint pain limiting her activity, comes back with a creatinine of 0.8, flagged normal on the printout. Run the numbers through the cystatin C-based equation instead of the creatinine-only formula, and her actual estimated GFR comes in at stage 3A chronic kidney disease, already meaningfully reduced. Nothing on her chart told her that. She felt fine. Her report said normal. That gap between what the paper says and what's actually happening inside the organ is precisely why nephrologists have started pushing for cystatin C to become standard, not optional, for anyone over 60, and why some health systems, including several within the Veterans Health Administration, have already changed their default lab ordering panels to include it automatically for patients in this age bracket. So what's actually happening inside your kidneys while creatinine sits there looking normal? Think of your kidneys as a pair of extremely fine coffee filters, each one built from roughly 1 million microscopic filtering units called nephrons. Every single day, those nephrons filter about 150 liters of blood, pulling out waste and holding on to the protein, sugar, and minerals your body needs to keep. You're born with your full lifetime supply of nephrons. You don't grow new ones. And starting around age 40, most people lose about 1% of their nephron mass per year. a normal expected part of aging. By 60, that's roughly 20% of your original filtering capacity, gone through ordinary wear. Here's where it gets important. The kidney is remarkably good at compensating. The remaining nephrons enlarge and work harder to pick up the slack, a process called hyperfiltration. Your blood tests stay stable. You feel completely normal. But hyperfiltration has a cost. It puts extra pressure on the nephrons that are left, and in people with even mild, undiagnosed high blood pressure or blood sugar irregularity, that compensating mechanism accelerates the loss of the remaining nephrons instead of protecting them. This is why kidney specialists describe chronic kidney disease as a disease with almost no early warning system. The National Kidney Foundation estimates that up to 90% of people with reduced kidney function don't know they have it, and the reason isn't that they're ignoring symptoms. It's that stage 1 and stage 2 kidney disease typically produce zero symptoms at all. No pain, no change in urination, no fatigue that stands out from ordinary aging tiredness. The first symptom many people notice is swelling in the ankles or persistent fatigue, and by the time those symptoms appear, function has often dropped into stage 3, meaning somewhere between 30 and 59% of normal filtering capacity has already been lost. The damage that got you there took years. It just never showed up on the one blood marker everyone was watching. Here's the part that should genuinely concern you if you're over 60. The biggest hidden accelerant of kidney decline isn't some rare disease. It's a medicine cabinet staple most people reach for without a second thought. Over-the-counter NSAIDs, ibuprofen, naproxen. The pills people take for a bad knee, a headache, or everyday arthritis pain. NSAIDs work by blocking prostaglandins, compounds that, among other things, help keep blood vessels in the kidney dilated, so blood keeps flowing through the filtering units properly. Block those prostaglandins regularly, especially in someone whose kidney reserve is already reduced from normal aging, and you constrict blood flow to the nephrons that are working overtime to compensate. A 2019 study published in the Journal of the American Society of Nephrology tracked adults over 65 and found that regular NSAID use, defined as several times a week for pain management, was associated with a measurably faster decline in estimated GFR over a 5-year period compared to non-users, independent of baseline kidney health. And this is the trap. Because creatinine lags behind real damage, someone can be taking ibuprofen 3 or 4 times a week for arthritis pain, quietly losing filtration capacity, and their labs will still say normal for years. It's not that NSAIDs are dangerous for everyone. For a healthy 30-year-old kidney, occasional use is essentially inconsequential. It's that after 60, when nephron reserve is already reduced by 2 decades of normal attrition, the same dose that was harmless at 35 is now landing on a kidney with far less margin for error. Combine that with the second under-recognized factor, chronic mild dehydration, which becomes more common with age as the thirst signal itself weakens due to changes in hypothalamic sensitivity. And you get 2 ordinary everyday habits quietly working against the organ system that has the least room in your entire body to hide a problem. Lifestyle patterns compound this in ways that rarely get connected back to kidney health specifically. Uncontrolled or borderline blood pressure is the single largest driver of kidney decline worldwide. The American Kidney Fund attributes roughly 1 in 4 new cases of kidney failure directly to hypertension, because every heartbeat sends a pressure wave through those delicate filtering capillaries, and sustained high pressure scars them over time exactly the way it scars other small blood vessels in the eyes and brain. Blood sugar irregularity does something similar through a different mechanism. Even glucose levels that fall short of a diabetes diagnosis, in the prediabetes range, have been linked in multiple cohort studies to measurable thickening of the kidney's filtering membrane over time. And then there's protein intake habits, which cut both directions and confuse people constantly. Adequate protein is essential after 60 to prevent muscle loss. We've covered that on this channel before. But very high protein diets, particularly ones built around processed meats and undertested with a physician in someone who already has reduced kidney reserve, do increase the kidney's workload because your kidneys have to filter and excrete the nitrogen byproducts of protein metabolism. None of these three factors, blood pressure, blood sugar, protein load, will show up as a red flag on your annual creatinine test until the damage is substantial. They accumulate quietly in the background for years. There's a fourth compounding factor worth naming directly: certain common prescription medications. ACE inhibitors and ARBs, prescribed for blood pressure, are generally kidney protective, but combining them with an NSAID and a diuretic at the same time, a combination sometimes nicknamed the triple whammy in nephrology literature, has been shown in a 2015 study in the BMJ to roughly double the short-term risk of acute kidney injury in older adults, especially during a bout of dehydration from illness, hot weather, or reduced fluid intake. This isn't a reason to panic about your prescriptions. Most of these medications remain appropriate and necessary. It's a reason to make sure your physician or pharmacist reviews your full medication list together, at least once a year, specifically asking whether any combination on it raises this particular interaction risk. So here is the actual protocol. 4 concrete steps, and none of them require guesswork. Step 1. At your next physical, ask specifically for a cystatin C test, or request that your doctor calculate your eGFR using the combined creatinine-cystatin C equation rather than creatinine alone. This is not an exotic or expensive add-on. Most major labs, including LabCorp and Quest Diagnostics, run it as a standard panel item, and it typically costs somewhere between $15 and $40 if not covered by insurance, though it frequently is covered when ordered alongside a basic metabolic panel. Use this exact phrase with your physician. Given my age, can we run a cystatin C-based eGFR instead of relying on creatinine alone? Step 2. Request a urine albumin to creatinine ratio, or ACR test, at the same visit. This is a simple urine sample, not blood, and it detects microalbuminuria, tiny amounts of protein leaking into urine, which research from the kidney disease. Improving Global Outcomes Organization shows can appear up to 5 to 10 years before GFR itself starts to drop on standard testing. It is, in effect, an early warning system that operates on a completely different timeline than creatinine. Step 3. If you take NSAIDs regularly for chronic pain, bring a written log of your actual weekly use to your next appointment and ask your doctor directly whether acetaminophen, topical NSAID gels, which have dramatically lower systemic absorption, or a physical therapy approach could reduce your systemic NSAID load, because occasional use is very different from the 3 to 5 times a week pattern that shows up in the research. Step 4. Track your blood pressure at home twice a week using a validated upper arm cuff and aim for readings consistently under 130/80, which is the threshold the American College of Cardiology now associates with meaningfully lower long-term kidney strain, because a once-a-year clinic reading, often elevated simply from the stress of a doctor's visit, misses the sustained pressure pattern that actually damages nephrons over months and years. One more practical note on timing. Ask your doctor to repeat the cystatin C and ACR combination annually, not as a one-time check. Kidney specialists look for the trend line, not a single snapshot. A stable eGFR from year to year, even if it's on the lower end of normal, is far less concerning than one that's dropping by 3 to 5 points every 12 months. That rate of decline, called the slope, is often what actually determines whether a nephrologist refers you for further evaluation, and it's completely invisible unless the same tests are repeated on a consistent yearly schedule. Now, 3 mistakes that quietly undo all of this. The first is assuming that a normal creatinine result means the conversation is closed. As we've walked through, that single number was never designed to catch the pattern of decline most common after 60. It needs the cystatin C and ACR context to mean anything definitive for someone in this age group. The second mistake is over-restricting water intake out of a vague sense that less is safer for aging kidneys. It's the opposite. Chronic mild dehydration concentrates the very waste products your kidneys are trying to filter and makes the filtration job harder, not easier. unless a physician has specifically restricted your fluids for a diagnosed condition like heart failure or advanced CKD. For most people over 60 without a specific medical restriction, adequate hydration, roughly half your body weight in ounces daily, spread throughout the day rather than in a few large servings, actually protects filtration capacity rather than straining it. The third mistake is reaching for popular kidney cleanse or kidney detox supplements sold online, often containing high doses of herbs like juniper or dandelion marketed as flushing toxins. There is no credible clinical evidence that these products improve filtration, and some, particularly those containing high-dose herbal diuretics or unregulated Chinese herbal blends implicated in past cases of aristolactic acid nephropathy, have actually been linked to kidney injury in case reports published in medical journals. If a product promises to detox or flush your kidneys, that marketing language itself is a signal to skip it and bring the actual conversation to your physician instead. Here's the reframe worth sitting with. Kidney function isn't something that fails suddenly at 75 or 80. It's something that erodes in complete silence for 20, 30 years, hidden behind a lab value that was mathematically built to miss exactly this pattern in exactly this age group. The test you've been getting isn't wrong. It's incomplete. And the fix isn't a dramatic lifestyle overhaul. It's 2 specific lab requests you can make at your very next appointment. A shift in how you think about the pills in your medicine cabinet and paying attention to a number, blood pressure, that most people over 60 already have the tools to track at home. The kidneys that carry you through your 70s and 80s are the same ones you have right now. There are no replacements waiting in reserve, and unlike a knee or a hip, there is no routine surgical fix once filtration capacity is gone, which is exactly why catching the slope early, while there's still function left to protect, matters so much more than reacting after a diagnosis. What you ask your doctor for next visit determines how much filtering capacity is still there to protect. If this opened your eyes to something your doctor hasn't mentioned, hit the like button and subscribe. We cover what doesn't fit in a 10-minute appointment. Visit healthhustleacademy.com. We've put together the exact tools and supplement resources we talk about in these videos. All links are in the description. Take care of your body. Nobody else is going to do it for you.